Greetings, everyone. Thank you for joining us for this month's panel as a part of the Lancet Commission on U.S. Health Policy's webinar series. And today we're excited to hear from a widely renowned panel of researchers, activists, and policymakers on the topic of drug policy and racism. The speakers, who I think are on the next slide. Actually, before I get to that, I want to make a few housekeeping points. You're welcome to submit questions, and we will have a period of time for questions at the end of the presentations. You can submit any questions at any time during the presentations. Use the Ask a Question box on the dashboard, and there's an image of that box on the screen right now. On the webinar dashboard, you will see a box with related resources, and a link to related Lancet content is featured there, and it will take you to the lancet.com. You can adjust or minimize any of the boxes that appear on the webinar dashboard to suit your preferences, and a link to the on-demand version of this will be emailed to you once the webinar has concluded. So that's one of the benefits of registering. You'll get a link to the recording. And so I want to first just let you know that the panelists are going to include Marie-Jo Frette-Rustide, who's a sociologist at INSERM, the French National Institute of Health and Medical Research, to be followed by Morgan Medlock. She is in the Behavioral Health Administration, the Department of Human Services, State of Colorado, and then Sterling Johnson, a Philadelphia-based activist, PhD student in Geography and Urban Studies at Temple University. And the topics that we're going to cover include, by Morgan Medlock, Creating a Just World, the Power of Centering Lived Experience, then Community Organizing by Sterling Johnson, and then Drug Policy Framings in France, Color Blindness, and Social Control Discourses. And so let's see, I believe actually that Morgan Medlock will be leading us off today. So let me give you a little background on Morgan Medlock by way of introduction. She is in the Behavioral Health Administration, as I mentioned, the Department of Human Services for the state of Colorado. She's the Behavioral Health Commissioner for the state of Colorado, and she's a member of the governor's cabinet. Thank you so much, Dr. Medlock.
Thank you very much, Dr. Hansen, and it's great to be here today. I want to acknowledge that as a global community, as we are supporting those we serve in their emergence from the acute stages of a traumatic pandemic that has shown the impacts of structural racism and its disproportionate impact on communities of color, I could come here today with a number of statistics to show how communities that have been historically excluded have been harmed in that context, but rather than present data that perhaps would only perpetuate deficit-based models of communities and what they're contending with in their lived environment, I would like to launch this webinar with a sense of hope and would like to lift up the topic, how do we co-create a just world, particularly for vulnerable communities by centering lived experience. I'm going to tell you a little bit about our journey in Colorado and how that has emerged to our commitment to co-creating a people-first behavioral health system. Our journey in Colorado really started decades ago, but culminated in 2019 with the creation of the Behavioral Health Task Force that was commissioned by Governor Polis. And this task force was asked to really play a central role in his administration to really respond to the outcry of Black and Indigenous people of color around the fact that their traditional behavioral health needs and access desires were not being met, that they were desiring a new system, a new approach to government in terms of how it partnered with communities of color. As a result, that task force created a foundational report called a needs assessment for the state of Colorado. And that assessment identifies that not only are people of color and our tribal nations in Colorado deserving of a more just system, but in fact, they made a recommendation to create a brand new behavioral health administration. And on the slide here, I'm defining what the BHA is. It is a new cabinet member-led agency designed to be the single entity in our state driving coordination and collaboration across all state agencies to really lift up whole person health. What does that mean? It means that we have reach to influence how individuals who may be justice involved experience and endure the criminal legal system as they may have substance use disorder needs. It means that we have formal agreements with the Department of Corrections, with our Medicaid agency, with all of our human services benefits partners. It means that we influence housing decisions. So this is a really vast approach to thinking about what we call the behavioral health ecosystem. And in Colorado, we are grappling with our core purpose, which for us really leans into this fundamental belief that every person in our state, irrespective of history, identity, disability, ability, status, deserves to experience whole person health. And we talk about that in terms of service environment, lived environment, physical environment, et cetera, how people access health services and particularly substance use disorder care. We envision a world in which behavioral health services are accessible, meaningful, and trusted. And I'm going to speak a little bit later about what building trust means for us as we co-create this system. And our mission is to co-create a people-first, a behavioral health system that truly meets the needs of every person in Colorado. I want to speak to our values as they emerge from this process since 2019 of the task force and then the administration. The Behavioral Health Administration is 6 months old. We launched on July 1 of last year, and we co-created even our values commitment with the people of Colorado and with diverse communities. And so I just want to unpack this a bit as we think about our objectives today. The people of our state requested that our leading value be truth. And what that means for us is that we must acknowledge when harm has been done, particularly to communities of color, and have a commitment to communicating transparently and accurately through data and outcomes. And so the Behavioral Health Administration has a comprehensive approach to storytelling through data and thinking through how do we ensure that communities who have historically been excluded, underreported, understudied, that their stories are reflected in how we co-create equitable policies. That leads to our second value of equity. We define equity in the BHA as naming root causes of injustices and allocating resources to support the desired outcomes. And so some of the unique drug policy approaches that we are piloting in our state include a tribal-focused crisis response team. We're also standing up a new tribal behavioral health center to serve our Southern Ute tribe and our Ute Mountain Ute tribal nations in the state of Colorado. We're also lifting up a workforce strategy that centers lived expertise and peer support professionals, as well as the Promotores de Salud model for community health workers in community. We also have a commitment to equity and funding, which means that we don't just send out grants that are necessarily the most well-written, but we think about grant programs that actually advance behavioral health equity, and how do we ensure that every dollar we invest actually promotes whole person health outcomes for Black, Indigenous people of color. Our collaboration value speaks to thinking about how do we collaborate across state agencies to really realize this holistic behavioral health vision. And so, for instance, with our partnership with housing and understanding how do upstream social and institutional inequities then lend to other crises in one's emotional and behavioral health. So those are some unique projects that we are engaging in. The governor has challenged us to reduce the number of unhoused persons by 50% by 2027. Community-informed practice for us means that we lean into the power of evidence-based guidance, but we also respect Indigenous leadership. And we acknowledge in Colorado that our communities are indeed experts on helping us co-create this new system when there's equity of opportunity. And finally, when we think about generational impact, for us that means creating a new legacy in our state where sound policy decisions today can hopefully lead to healthier individuals, children, families, 3 generations from now. Next, I want to kind of talk about what it means to be a community anchor and how do we do that from the lens of state government. We talk a lot in Colorado about the importance of lifting up lived experience and especially local efforts while elevating our collective cause. And so for us, authentic partnership is really the key to achieving this larger vision. Our first commitment is to acting responsibly and in the best interest of every person in Colorado. One of the unique opportunities we have is Colorado was part of an interstate compact where we participated in litigation against pharmaceutical companies who contributed to the opioid crisis. And as a result, we have a historic influx of funding, over $500 million. We are committed to investing over 90% of those funds in local communities. One of the things the Behavioral Health Administration has lifted up is that a historic infusion of funding does not address community trauma. And as we want to move forward, we have to acknowledge that dollars does not address the legacy of exclusion that has occurred not only in the United States, but globally. And to really heal, we have to lean into the power of co-creation, sharing power, allowing communities to center their stories, and allowing their individual narratives to be appreciated as we move forward. We also believe that it's important to obviously acknowledge when harm has been done and take purposeful action towards meaningful remedies. One of the things we have done in our state is we have established a statewide lived experience council, and that council has representation of 40% members of Black Indigenous communities, as well as our Southern Ute and our Ute Mountain Ute tribes, over 50% representation of rural Colorado, and over 50% representation of individuals who may be experiencing a disability or who have a family member with a disability. That council has been elevated in our state to be the core convener and advisor to the Commissioner's Office on how we move forward into this new future. With this council, we're co-creating a new comprehensive data strategy that centers community experience and Indigenous leadership in deciding upon agreed upon metrics to achieve behavioral health equity and expanding ultimately our landscape for creating efficiencies and new possibilities. And so this whole framework of co-creating a just world for us is really built around bringing solutions with community rather than to community. And that requires us really engaging in capacity building and relinquishing deficit-based models of community, acknowledging that communities are indeed where the expertise lies, and that historically their strengths have simply not been highlighted or uplifted. And we're committed to that work. I want to just, as I close, share a quote from the co-chair of our statewide Lived Experience Council, who has reflected upon her experience, co-chairing and sharing power with state government in her role as a chair of the Advisory Council. She is a woman of color, and this is how she articulates what it means to really share power at the state level. She writes, "This is so surreal. Never did I think that getting sober 12 years ago would bring me to this moment in time. As a sober and healed Black woman, I am making history. This appointment is for my ancestors who were enslaved and for my father, who was segregated until he was 18. He was never given that chance to heal his soul. This is for them." So what Raquel is articulating is that when we have people-centered values at the state level, and when we're committed to authentic partnership, it really does create the power to heal historic injustice. And so my final slide today will center us on the fact that really what I'm talking about is creating a just world by leaning into this well-known mantra of nothing for us without us. In other words, we believe that innovation on its own does not serve the people of our state, nor does it serve our global majority. Good innovation is really rooted in people's needs and improvising our system processes to support people. So our framework in Colorado is really centered on people, process, and performance. And we talk about listening to the people of Colorado first, establishing processes that support people, and then thoughtfully systematizing the ways in which people engage in state government and process. Thank you for listening to this framework for co-creating a just world by centering lived experience. Thank you, Dr. Hansen.
Thank you so much, Dr. Morgan. I want to turn next to Sterling Johnson. It's my pleasure to introduce him as a major activist in the National Survivors Union. He's also a PhD candidate in Geography and Urban Studies at Temple University, and they received their JD from the University of California Hastings College of Law in the US and a master's in geography from George Washington University. Since 2012, they have lived in Philadelphia and focused on supporting housing and harm reduction in Black communities. Thank you.
All right. Thank you, Helena, and thank you, Morgan, going before me. That really set the table. terms of what needs to be done in terms of learning and listening from especially Black and Brown communities. So the title of mine is just related to community organizing. At this time, I'm really in the depths of a PhD, so I'm doing a lot of that work. But I wanted to talk about some of the work that I've been done in the last 2 or 3 years. Let's see. All right. So just as an introduction, I just want to be clear about my identities and where I come from. This is, the United States is stolen land. It's really important to recognize that and not make claims that are inappropriate or part of the genocidal project of the United States. So a lot of the work that we do is really based on understanding that in terms of stewardship as what we should do, and especially as Black people that were enslaved in this country. I myself and my family think about this place as the place that we are right now, but also we are stewards, especially from the environmental perspective. I'm also a queer person, also a disabled person. I would say that I'm an activist. I don't know what that means really, but it seems to be the title that fits. And I have a history of being in some nonprofits around that have done lawyering and mental health advocacy for individuals in their space. I mean, these other things, I have been inside of a mental hospital as a patient. I have received substance use treatment. I am a part of the National Survivors Union, so I'm a drug user. And I'm HIV positive, so I have that experience to just as like part of my identity. And from there, I just wanted us to think about my particular city. Like Elena said, I've been in Philadelphia since 2012, and been here. I'm not sure if you can how big that is, but over the last 5 years, we've had over 1,000 deaths a year. This is from Pew, and there doesn't seem to be any stopping it. And consecutively, at the same time, we've had a lot of homicide deaths. There's a lot of harm that's happening in our city, and I want people to understand that, I come from this perspective, just being in my family and my neighborhoods, but I often hear something like, well, there's more overdose deaths than homicide deaths. And at least in the Black community, those are harms that are the same. That is about the organized abandonment and disinvestment in our communities, and those both need to be tackled at the same time. So I just wanted to say that. And with the organizations that are in my city, they have done work around abolition and defunding the police, and people continually say they want affordable housing, they want quality schools, and they want mental health services that actually meet people's needs. Going to the next one. And in terms of the organizing that I have done, what was doing from around 2017, we with other people in the city, really just a loose organized group of people. We are talking to people that are unhoused in our city, kind of understanding like what they needed. Also getting some really good technical assistance from people like the Western Regional Advocacy Project, which does homeless organizing in San Francisco. And I think from here we're really starting to figure out like what is the production of knowledge. From our standpoint, it was finding that people wanted autonomy, people wanted homes that with enough space where they could have friends or family. They wanted to not be to not have visitation that was in a living room. They wanted to have somebody in their home. In their bed. They also wanted a safe and regulated supply of drugs and not to be sober. So those are some of the things that from our organizing, we knew that that's what people wanted. And it was our job to as we begin to think about like, what are we doing? What are we doing? It was not for us to say, oh no, this is what's possible. It was more about, okay, that's what you want. Okay, let's figure out how we actually get to there. And here I'm going to address to the 2020 encampment. Through years of organizing with individuals, it was we really saw 2020 as this opportunity for us to, I guess, take it to the next level. It was about attempting to stop every sweep that was happening in the city, which we would hear about, and then we go out and confront them. We have people in different organizations that know where the sweeps are happening, so we would just use that intelligence to kind of go after them. Even when I worked for a nonprofit, it was important to stand against that, because there wasn't housing for people, especially for people that were using drugs at the time, and to advocate for housing first. Ultimately, we would have meetings with the homeless services, and they decided they would continue to do that. So from there, basically, we had to make a decision about what our next move is, because they would not stop. My comrade, Jen Bennett, who has passed away of COVID earlier this year, really kind of had this three-pronged approach to this. It was to stop sweeps where they were at. We would then squat houses, because there's a lot of vacant property in the city of Philadelphia. And then we would have an encampment that would bring attention to the problem of housing. And it was really important to not separate this idea of housing and homelessness, because much of the housing issues are evictions, or people being evicted and then they're going to the street. And it was also part of our work was thinking about abolition, which is people's and policing. And so you're against police. The homeless services acted as the police, and then child protective services is who would basically take people's children away even while they're homeless. And this of course was kind of informed by people that experience homelessness, like our friend Jen Bennett, who's at the top there, and also Teddy, who is a person with a developmental disability, but he also just had this very clear idea of what he wanted, and it was important for us to fight for that. And it was to listen to that. And we really try to put together the idea of, you're experiencing this, and this is what your solution is for at this moment. Sometimes we're talking about identities, which I try to go away from, where I'm looking specifically at what is somebody experiencing, and how do we actually solve that. And through this long encampment, 5-month encampment, which is very tiring, and lots of things happened around it, and lots of harm happened, but lots of things, lots of positive things happened too, around people getting housing. And part of the deal was giving us 50 houses from the Housing Authority, who was gentrifying parts of North Philly. So we were able to get that, and we're still working on transferring those vacant properties into a land trust. Additionally, all the people that we squatted houses with, which are mostly Black mothers with children, were able to be safe, and nothing happened to them. But part of it was this idea of we actually are going to fight for the thing that people want, because we're listening to the people. Where I talk about the actual community organizing part of it, which I have a lot of learning to go along with this too, is organizing among understanding the kind of violence that can happen in the organizing world, understanding that mask identified people really need to be doing their own work. When we're asking for decriminalization or the pulling back of police, there has to be this idea of this other forward care space that is actually happening. So that means a lot of work. I draw a lot of my work on Ruth Wilson Gilmore, who is a geographer, she always says abolition is presence. So I start to not think of abolition as something not being there, but of like something actually being there, because the homicide still exists, the overdoses still exist. What is the actual getting to that? And decriminalization, which of course is what we want, decriminalization of sex work, decriminalization of drugs, does not exactly equal us having a job. So we start to think about like where the money that people, at least our experience, that like people want to work, people want to have sovereignty over their own lives. So when we're fighting, we're also fighting for the transition to people that are using people that are selling drugs on the street. They have to have a transition to jobs that actually pay them enough to actually do what they want. And even if that means figuring out that in terms of the environmental space, I don't know, there are many job categories I could go into, but for me, when we're talking about like how we develop the community, our people and the community, it is about providing the care and space for them to actually live economically like thriving like lives. So I just want to give us that kind of understanding when we're talking about the fact that at least when it comes to kind of the racial justice frame of this, people are understanding that we really have to decriminalize drugs and all these crimes that aren't really crimes. It's like what is the crime is that there is not sufficient care and economic vitality and ability to feed your family and ability to care for your family in a long-term way, and a long-term investment in our neighborhoods. So when we're doing our advocacy, we're constantly looking at that. And from just my experience, it's important to think about I think that this is the challenge for us, and this is the challenge for all of you as well that are listening to this. I find it is in the sovereignty, the housing sovereignty, the food sovereignty, the healthcare sovereignty space. For us, having control of a land trust that is run by like people that have experienced displacement, not just Black people, but people that have experienced displacement, is extremely important. We've worked with people that are experiencing homelessness. We've been working with the affordable housing group that where they're being displaced and thinking about how they can actually take control of their housing. We've been having yearly conversations with Black and brown, queer and trans people here in the city of Philadelphia to think about what does community control of health look like? Because when it seems that no matter what, the power structure seems to constantly be the same thing seems to happen, where when you're hiring a lot of people that have lived experience, we're always at the bottom. I think another, like, the way that we can do it is by having ownership of our own organizations, having those organizations be accountable to people. And that seems to be the way, and what people can do is support those organizations in a way that makes sense, especially over the long term. And I'm currently working with the National Survivors Union, which is the kind of national drug users union in the United States. Louise Vincent and Abby Coulter and Katie Simon are drug users that are drug user activists that have been in this space for a very long time, so for decades, and we want to draw upon that expertise when we're moving forward about what meaningful engagement of drug users is in terms of being a part of organizations and really having this long-term investment in them, as well as like giving us the ability to have investment in organizations that truly like value us. And I think for me that's been really hard, as a person that's been in the nonprofit complex. I just want to say from that, like, I am a person here who definitely draws on the expertise of other drug users in ACT UP Philadelphia and other people that have helped me get to where I am right now. And we try to actually, one of the things I try to do is say, like, what is the how of getting to where we're trying to be? And the liberation path is quite complicated, but I think as long as we're willing to get into the weeds of that and getting into the dirtiness and messiness of it, I think that's where we are. That's what we need to do. And I think, hopefully you've learned something and can understand that just where I'm coming from, and also and how this matches to larger fights and research, and also from the governmental perspective. So thank you for your time.
Thank you so much, Sterling. That was so mind-opening. And I now want to turn to Marie Geoffret-Ristide, who's a sociologist at INSERM, the French National Institute of Health and Medical Research. Marie leads INSERM's research program on risk management and addictions and surveys on the health of drug users, consumption practices, and the social and political context of exposure to the risk of HIV and hepatitis. She's a research fellow at the Center for the Study of Social Movements, the scientific director of the Social Sciences, Drugs, and Societies program at the School for Advanced Studies in the Social Sciences in Paris, and is affiliate research scientist at the British Columbia Center on Substance Use, Vancouver. Marie is also senior research fellow at the Baldy Center for Law and Social Policy at Buffalo University in New York. Thank you.
Thank you, Elena. So first of all, I would like to thank Elena Hansen and also all the Lancet team for inviting me today to be part of this wonderful panel. So I will begin in my introduction, and I will try to explain to the audience why in France there is still a color blindness discourse about drug policy, but also beyond drug policy. So difficulties in highlighting racial inequalities are explained by the French Republic Universalism prism that is dominant in France. So with this framing, people who belong to the same nation need to be considered as equal citizens with the same rights, regardless of their origins. And the welfare state, the French welfare state, plays a major role in creating this artificial unity. So this framing brings about a colorblind political discourse that is unfortunately unable to publicly recognize the existence of discrimination against people of color according to French colonialist ideology. And because of this framing, ethno-racial data are not allowed in France, and researchers are not really able to show racial inequalities based on number. But hopefully we also have sociological and ethnographic data that help us to highlight how drug policies have been marked in France by racism. So now I will move to the beginning of the French drug policy in the period of the 1960s to 1980s, and I will try to highlight how it has been framed as a white youth problem. So on my slide, I show a French journal that is in French and that shows that the beginning of the French drug policy happened in a very specific context. So a young white woman called Martine died from a heroin overdose in August 1969 in Bandol, a village located in the south of France. And the media coverage, as you can see on this slide, highlighted the deaths and dangers of drugs for young women and created a moral panic among French public opinion. During this period of time, and that's still the case, now women were and are still presented as vulnerable people enslaved by drugs because of men in the media discourse. In reaction to this dramatic event, the death of a young woman, the French law regarding illicit drugs was voted on a specific context on December 31st, 1970, in a very sensitive and emotional political context in France, just after the student revolt of May 1968. And this period of time and this revolt of May 1968 was instrumentalized to push the vote of different laws dedicated to the control of protest. And that's why the French law regarding drugs in France is so repressive. So in the 1960s, the political public framing of drugs was not primarily focused on the question of race, but rather on the social and political question of youth protest that must be both repressed and protected by a strong law so that they avoid the dangers of drugs. The prohibitionist law of December 1970 shows and highlights that the role of the French government is to protect and control young people. And there is a French paradox. In France, we have a combination of a very repressive approach to drugs, but we have also a strong harm reduction policy. Drug treatment and harm reduction are free with sustainable public funding, and this sustainable public funding has been implemented explicitly in order to reduce social inequalities, and in practice, it also reduces partially racial inequalities in access to care. As you can see on my slide and on these press articles, in the 1960s to 80s, people who used drugs were often represented in the media as white people. And also in political imaginations, people who used drugs at this period of time were represented as white people. Whereas dealers were always represented as migrants or children of migrants from former French colonies. I will now move to the political frame of the crack cocaine epidemic that happened at this period of time in 2023, and that began in 1986. So the general framing of crack cocaine in France is very different to that of heroin. It is characterized by both an intersection of open drug use in public spaces with crack cocaine's association with low socioeconomic communities and migration. Even though no specific statistical data on race have been collected in France, the first ethnographic data about people who used crack cocaine in the early 90s describe them mainly as people from former French colonies in overseas territories, which essentially implies that they are people of color. Since 2020, there has been in France a strong intersection between crack cocaine use and migration from Western African countries, thanks to the spatial proximity of encampments of poor migrants and open crack cocaine drug scene that have been moved to the suburbs of Paris. As usual, France combines a political model that focuses on French state intervention that aims to repress, control, and take care of people who use drugs. And it also applied to cocaine crack situation. In the case of cocaine crack, the dominant concern is public order, and a new figure has come to the fore. These new figures are the local residents who, in French media, symbolize French citizens that are considered as vulnerable people exposed to disorders caused by crack cocaine users in the French political discourse and in the French media discourse. In September 2021, this repressive policy was symbolized by a wall that has been built by the police to avoid people who use crack cocaine once again moving to gentrified residential areas in the northeast of Paris. This repressive French approach is focusing on public order, but also on public health, with a slogan from local residents who live near open drug scene that said, cure them, people who use crack cocaine, and protect us, the residents. French political and media discourse is still implicitly colorblind regarding people who use crack cocaine, but it explicitly presents an intersection with social class and migration. In France, the racialization process and discourse is also applied to religion, to people who are Muslim, and also to white people from Eastern Europe who are poor. In the media, people who use crack cocaine are always presented as devils, mad people, with a semantics that refers to public insecurity. Politicians and residents speak very loudly about people who use crack cocaine and ask the welfare state to keep them far away from them, the residents who consider themselves as citizens, and they want to force people who use crack cocaine to abstain from drug. People who use crack cocaine are more rarely considered to be people who suffer from structural violence, and they are also rarely allowed to produce narratives about themselves. People who use drugs in France, and especially those who are the most vulnerable, people who are racialized, people who are poor, women, are often silenced in the media. Their voices are totally ignored. But hopefully, there are new forms of social movement of people with lived experience that try to bring their voices into the public debate. Women are both stigmatized and presented as vulnerable people, women who use drugs, and some of them are involved in a new movement called the narco-feminist movement. And in this movement, these women are also recognized as people who possess individual resources, who are able to deploy risk reduction strategies, and people who have the capacity to take action. The narco-feminist movement is defined as a narrative reforming movement that brings together women who use drugs in all their diversity to challenge outdated, stigmatizing, and patriarchal narratives about women's bodies, women's choice, women's rights, and women's voices. These women can reclaim their stories through an auto-ethnographic feminist approach that denounces relationship of oppression, produces new subjectivities, and invents new forms of resistance to discrimination. I will now conclude on war on drugs and social control. So French and US histories of drug prohibition reveals that prohibition usually works in the service of goals external to the drug itself. This may be the management of one or more social problems or moral panics, such as youth culture, class inequalities, racial inequalities and rights, gender rights. And even if France is colorblind in its political discourse, the repressive drug policy produces in France a form of stigmatization towards racialized people, poor people, and women. But in France, it happens in a context of a welfare state which happens to give access to health to all French citizens, and that's what we can call the French paradox. So thanks a lot for listening.
Thank you so much for that very revealing international comparison. And I now want to call forward a very special discussant who will start off our question and answer period. We're really privileged to have Joseph Gone. He's professor in the Faculty of Arts and Sciences in Anthropology and in the Faculty of Medicine in the Global Health and Social Medicine program at Harvard, where he also serves as the faculty director of the Harvard University Native American program. So I have asked him to lead us off with some comments on the presentations. Thank you, Dr. Gone.
Thanks so much, Dr. Hansen. It's a pleasure to join you all today, and I'll just say a few words to try to frame a bit how drug policy and racism touch on indigenous communities in the United States. So I'm a professor, of course, a psychologist. I study this sort of issue, but I'm also a citizen of the Aani-Grovant tribal nation of Montana from Fort Belknap Reservation. And it's important, I think, for this audience to understand that when it comes to American Indian and Alaska Native people in the United States, because of the history of treaty making as international polities with European powers in the United States, our communities are recognized as sovereign nations, which is to say that we exercise powers of self-determination and self-management within our reservation settings in ways that are quite distinctive from any other group in the United States. The Constitution of the United States actually doesn't apply to Indian country in this sense, except where Congress has sort of said. So this is a really important background that sets up a very distinctive services ecology when it comes to substance abuse treatment and management in Indian country. Obviously, the big issue to keep in mind here is the history of colonial subjugation, first with European powers, obviously with Euro-Americans in the United States. And the primary way that people in Indian country language the legacy of harm from colonial subjugation in the context of mental health and substance use or abuse is indigenous historical trauma. Historical trauma is really preferred in many instances to the language of the medical professions when it comes to behavioral health issues or challenges. Indigenous historical trauma is really grounding or anchoring the origin of these problems in colonization, which of course involve dispossession of our lands and theft of our resources and captivity on reservations and then starvation and all kinds of other horrible federal policies that were to our detriment. And the legacy of drug harms actually comes from our legacy of colonial subjugation as well. You know, where I'm from on the Northern Plains, we first encountered alcohol through European trade to facilitate commerce and so on. And so addiction to substance use was unknown in Native North America prior to European arrival. In any case, it is the case that in our communities, too many of us are medicating our misery, and addiction remains probably the single most salient and prevalent mental health problem to afflict our communities. We have an article coming out soon led by Joe Friedman with Dr. Hansen and myself that will talk about deaths of despair relative to Native American communities, because actually that discourse, as it's arisen in the past 5 years or so, it applies to Native communities for a very long time, and yet we've been totally ignored with respect to some of those impacts. I think I'll just close by mentioning a few implications for drug policy and prevention. The first is because we are sovereign tribal nations and we have exclusive control and jurisdiction over our own territories and citizens, it is even more important to echo the words of Dr. Medlock that there's nothing about us without us that is undertaken, and that's actually legally enforceable in the context of indigenous tribal nations. And so all of the activities that we undertake will necessarily be in partnership or collaborative, often with federal dollars that are then administered directly by tribal nations to try to address these concerns. And it's interesting to see what tribes do when they have that kind of control. So for 50 years now, tribes have been assuming that sort of authority over substance abuse treatment in our own communities. And what tribal nations often do is integrate traditional ritual, ceremonial, and healing practices into those services. Sweat lodge ceremonies, for example, have become ubiquitous in substance abuse treatment that's controlled by tribes. That began, again, in the 1980s. But increasingly, there's interest in revitalizing and reclaiming other kinds of indigenous healing traditions that can then be integrated into substance abuse treatment, because a big part of how substance use is framed is back to indigenous historical trauma as, in some ways, the undermining of a robust, healthy indigenous identity. And so reclamation of that kind of identity, which can happen in part through the ceremonial, ritual, and religious participation, is part and parcel of the recovery rehabilitation effort. With that, I'll say thank you for allowing me the floor to kick us off and turn it back to you, Dr. Hansen.
Thank you so much for that amazing framing. So we have great questions here, and I want to encourage more questions to be posted in the Q&A box. I want to start with the domestic question. I'm going to give a general version of it and then a more specific version that's posted in the Q&A. The more general version is I'm just reflecting that all panelists and the discussant held up an alternative paradigm for drug policy that really privileges people who use drugs, and especially those who are marginalized within our racial hierarchies. So privileging them as those who need to develop solutions to the current problems of harms and death from drugs and from the drug policy that we have, and also to them to control the resources to mount those solutions. So this is against the grain and surely generates resistance within our current political orders, both in the US and France. So I wonder if the panelists can provide very briefly some examples of successful strategies to overcome that resistance and to redistribute power, The more specific version of that question that was posted in the chat has to do specifically with decriminalizing drug use and whether this would require a state-by-state strategy in the face of right-wing resistance, or whether there are other more promising strategies. So I'm going to hand this over to the panelists. Who would like to begin?
Dr. Hansen, I can take a stab at the Colorado context. So I think that all of these issues, do depend on courageous leadership. And in Colorado, I wouldn't be able to speak as I did today without a governor who appointed me to lift up these values and, in fact, hired me for an anti-racism approach to how I administer behavioral health services in the state. So I think it does take visionary leadership to set the platform for how these co-creative approaches move forward. I think the larger question around what does the national and global strategy look like in light of the rise of different political movements that are antagonistic to equity approaches is a complex question that we obviously need more than 10 minutes to answer. But I think even there, the answer lies within our hearts, and do we have the courage to continue to lean into the effort and investment that it takes to really continue to lift up the voices of those who are directly impacted by such policy. So that's a complex question that I think other panelists can help us with. But I do think it comes back to having courage, having the right leadership in place in these respective jurisdictions.
Thank you. I wonder if Sterling or Marie Geoffret-Ristide have some input.
Yes, if I may, I can say very few words about France. In France, you talk, Elena, about solution and how to involve people with lived experience. So in France, I think that if we have harm reduction that is sustainable, and if we have a very high access to opioid substitutive treatment, that's also explained because people with lived experience were included in a lot of meetings with governmental, with people from the government. And when people from the government hear the stories, the narratives of people with lived experience and how they suffered from a prohibitionist approach and how they suffer from the lack of harm reduction, people from the government in the 80s and 90s were totally convinced that it was important to implement harm reduction strategies. So that's why I think that inviting people with lived experience, not only to, that's important to invite people with lived experience to speak in the media, to sensitize the public opinion that they also are citizens, but it is also important to invite people with lived experience in all the areas where the decision for drug policy are made.
Thank you. Thank you. I wonder, Sterling Johnson, do you have any comments on that?
Yeah, I wanna kind of give the context of where I'm at. This is the United States in an East Coast city that has a lot of capital in it, that has a very deep nonprofit complex as well. And I want to kind of piggyback on the question that Philippe has in the chat around having a DA that is useful around supporting a lot of the work that we're doing. And that DA, which is ran on police reform, has really helped in terms of kind of drawing back a lot of the laws and the enforcement around that, and really demobilize a lot of the on-the-ground police in terms of enforcing unjust laws. And I think that's where I push us to say, well, what is a positive care? What does a healthcare sovereignty look like? Right now, that is not, I just can't say that that is what we have. I mean, we are maybe 40 years into this space of the AIDS epidemic, where we've had Black-led organizations, colors, we have Latino organizations. Those people are still alive, but those that have founded those organizations. However, what they saw was this lack of support on a long-term basis and believing in those organizations as supporting their communities. I'm not going to, I feel like I'm trying to have a very honest conversation about what has actually happened over the last 30 years, where there has been even a move from organizations that were founded during the AIDS epidemic, like Mazzoni Center up in Philadelphia, or Housing Works, just like these organizations that were founded by ACT UP, organizations that have now been more professionalized, and we need to understand that we have to have this commitment to this community, instead of kind of just turning public health into this other way to professionalize and to like these services that are really meant to be at a much smaller scale. I think the issue of scale is what I find to be the issue over and over again, because there isn't a positive health organization right now that I can really speak to that feels really good. There are a lot of them that are struggling, that are trying to get dollars, but like that just doesn't exist in this. We're deep. New York, DC, these places have these organizations. They exist, but their EDs have also been arrested. It's like I'm like, what does the sustainability and the training up of people to really support these places that what does that look like? I think we got to get into the weeds of this.
That's such an important observation. I am dialing in from the seat of professional mental health, the UCLA Department of Psychiatry, and many of my colleagues who are very community-based talk about the commercialization, frankly, and industrialization of the nonprofit sector in the U.S. So organizations that were founded on the blood, sweat, and tears of people with lived experience can easily be taken over by people with professional degrees whose lived experience is not close to that, particularly when there's an infusion of funds. And I have in mind what Dr. Medlock said about $500 million being available because of pharma company lawsuit settlements in Colorado. What is going to happen to that money? People who are professionalized are in a very advantaged position to steward that money, as opposed to people. So we talk now much more in my world of mental health people who want to move more to community-based services of the expertise of lived experience, that we need to really privilege, lift that up. And as you're pointing out, not only on the individual level, but the organizational level. So thank you for bringing that point. We have a couple of minutes left. And I want to put forth, there are two different questions that in my mind are related because they have to do with international lessons learned, translation and adaptation of lessons across countries and drug policy. So the first question has to do with policy platforms of international organizations and country organizations that the UN are supporting. How could international organizations such as the UN, WHO, UNODC, UNAIDS, et cetera, support the kinds of initiatives in the US that have been described in the panel? And then there was a related question about African nations and what they can learn and benefit from in the lessons learned from the US and France. So any panelists want to address that?
I can answer on African countries, if I may. So I just want to share with the audience that in several African countries, there are also more and more people who organize themselves, people who use drugs who organize themselves. And they have a fantastic power to make changes in their country. And I think that it's important to highlight this experience of community organization in Africa, because they are not very well known, but they are very, very powerful in practice for people who use drugs.
Thanks so much. We're at the end of our time. I wonder if there are parting thoughts from other panelists.
Well, in closing, Dr. Hansen, obviously the United States is in a place where the president has called out the development of a federal mental health strategy. And so those of us who are listening today, who are policymakers and experts, obviously we need to be advocating to ensure that that federal strategy is aligned with these values. Thank you. Absolutely.
And one example of, I'm just coming back to Sterling Johnson's point about the commercialization of funding for drug-related services and how to privilege people with lived experience. I just want to mention that the U.S. did under the peak of AIDS activism in the late 80s, early 90s, because of that activism, develop a policy innovation in the form of the Ryan White Care Act that required federal funding for HIV and AIDS to be shepherded on a local level by community councils that required a certain number of people with lived experience and people from heavily affected racialized communities to be present and be decision makers about use of funding. So, you know, we do have, if we look at the AIDS pandemic and activism, examples of how people with lived experience, people from racially marginalized communities can be privileged and uplifted with regard to use of funds and decision making. So any thought from you, Sterling Johnson, as we close?
Yeah, I say, especially from that experience, it seems even more important to use dollars for organizing, for creating spaces for people with lived experiences to have conversations, not through any mediator, but interlocutor or anybody, just with each other. And I would say that goes definitely across, that goes internationally. That's what I learned so much when I learned from other people's experiences. And it's really important that people at the nation state level are able to combat the U.S. wrong drug policy. You know, I think Uruguay and Jamaica and of course people like the coca growers in Bolivia. Those people are doing what needs to be done. It's like if anything, people in the United States need to be learning from the global South about how you would support people that are growing or people that are selling in our own context to then create this other economic way for them to live. You know, I think I just learn a lot from people outside the United States, honestly.
Thank you so much. And on that note, I want to thank the panelists and the Lancet staff for an incredibly enlightening and internationally enlightening discussion today. Thank you.